All right. Thank you for the introduction. So today I'll be presenting on sedation, analgesia, and nutrition. So after you intubate the patient, you need to continue the patient on sedation. And generally, as for now, there's no particular guideline to actually say for patients, for COVID patients. So the general guideline is used is based on intensive care protocol that is used in our country, and of course, this is guided by the international evidence and guidelines, and the latest would be the PADIS guideline in 2018. So after patient is intubated, as patient requires ventilatory support in COVID, which indicates that they have problem with their oxygenation and require and would have high ventilatory drive, we tend to keep them sedated so that they have less ventilator dysynchrony, and of course we rest the patient. So over the years, for non-COVID patients, before the era of COVID, it has already noted that the importance of sedation and analgesia. The focus has moved towards, have evolved towards effective pain management and with the aim of light sedation. So the principle is mainly to start the patient on analgesia, which commonly in our case we use opioids, which is fentanyl and morphine. Then once the analgesia is well achieved, we continue with sedation. And of course, what's important is to titrate the analgesia and sedation with the lowest effective dose. And what's most important is to have a frequent assessment of the pain and sedation using validated monitoring tool. So the purpose of this using validated tools is mainly so that we are on the same, we standardize we make it standardized so that our conversation is at this, we understand each other when we mention something such as patients is in deep sedation, Riker -3. And of course, what is highlighted in this slide, which is the one that we commonly use, is revised Riker. And for light sedation, it would be a scale of +1 to -1. Whereas for deep sedation, it would be a -2 to -3. So basically, our aim, the best would be when patient is awake and calm for light sedation. However, if there are certain conditions, especially in COVID patients, when they are newly intubated, they are in ARDS, you wouldn't want them to have, you need to control their ventilation, rest their ventilation. You may need to put them in deep sedation and keep them unarousable. So another common scoring that is used is the Richmond Agitation Sedation Scale, which is also known as RAS. So either one is used and is actually used nationwide. So it depends on your local protocol. This two is the most common used scale. So it's important to actually just carry out the assessment every frequently and with a minimum of 4 hours preferably. So the principles of sedation is, of course, based on PADIS, is that a non-benzodiazepam is generally preferred. However, the problem with using non-propofol and dexmedetomidine, which is commonly known as Precedex by its brand name, is that it gives a great what you call impact on the hemodynamic, patients would tend to require inotrope with the use of propofol. And of course, the drug availability and the cost is very high for with the use of propofol and Presidex, and it may not be available at this point in some centers, and not to mention due to the limited stocks, and not to mention it's very costly. And now that the pandemic is rampant, we are running out of stocks very quickly. However, if you all do notice, when we use benzodiazepine at high dose, towards weaning, you do realize that this group of patients tends to have very great incidence of delirium. So for patients who are hemodynamically unstable, you might actually want to use midazolam or use high-dose fentanyl. However, it is also to be noted that in patients with the use of fentanyl, despite being high dose, you should give it slowly, as a sudden bolus of fentanyl might cause chest wall rigidity, which will impair your ventilation. So, of course, who are not suitable for light sedation? Basically, those who need deep sedation are basically those with head injury, post-cardiac arrest, those on high vasopressors or inotropes, those on high ventilator settings, which is very common in our COVID scenario, those that requires prone position, or those have massive pulmonary hemorrhage, or those who are having severe airway obstruction. So deep sedation, as I mentioned earlier, is basically with the aim of a Riker of -2 to -3 and a RASS score of -3 to -5. So to achieve deep sedation, what is generally used is midazolam and propofol, or combination of both. So although benzodiazepine is associated with delirium, there are certain it has some benefits as well, especially in patients that have that you want to do some procedures such as a chest tube insertion, or patients who are seizing away, those who have substance abuse or alcohol withdrawal. The use of benzodiazepine it tends to be beneficial. And of course, towards the if patient is not well and towards the end patient is gasping away, it helps in palliation by and reduce the gasping. So these are the common sedatives that are used. So midazolam is generally quite hemodynamic, gives good hemodynamic stability as compared to propofol, which is generally used at the rate of 1 to 2 mg per kg. So this for induction. Infusion dose of 50 to 200 mg per hour, and never to exceed 400 mg per kg per hour, as the concern of propofol infusion syndrome is something to be wary of. So another drug that is used is Presidex. Usually is given at 0.2 to 0.7 mic kg per hour. As for the dilution, 1 ampule comes in 2 mils, and it's 100 mic per mil concentration. So that will give a 200 mic, and it will be diluted in 50 cc, and it will be given according to your local protocol. There is a chart to it. However, so the concern about the use of propofol is generally it will cause a great amount of hypotension and some degree of bradycardia. So in patients with propofol, you might actually want when you give propofol as infusion, there may be a need to put the patient on inotrope or vasopressors. Whereas for Presidex, it would have cost, it is noted that it costs a great amount of bradycardia as well. So patients who are bradycardic, you might want to use it with caution. The good thing about propofol over midazolam is generally that it has this extrahepatic metabolism, which means that it doesn't accumulate that much as compared to midazolam. If you all do realize patients that are on midazolam, sometimes when you wean them off, it might take up 24, up to 48, up to 72 hours for them to be weaned off to regain their good conscious level. Whereas propofol have the extrahepatic metabolism, meaning that even if it has other pathway to metabolize the drug. So the good thing about propofol is that it has this fast onset and fast offset properties, which is actually very ideal. And depending on your centers, there are a lot of generally when patient is intubated, we use and we want to achieve a deep sedation. Generally, we use midazolam for the cost effectiveness, and gradually towards weaning and extubation, we switch to propofol and or Presidex. So I'll move on to analgesia. So it's important to make sure that patient is pain-free. So it's also important to monitor them frequently. And the skills that we use, validated skills are such as behavioral pain skills and your critical pain observational tool. But in general, you see a patient, a pain is perceived easily when you look at the patient, by looking at the patient, but that is quite subjective. So to make it objective, the things that is done is to look at the facial expression, the limb movement, how is the patient dealing with the ventilation, and of course the muscle, the muscle tension as well, and the body movement as well. So, and of course, in patients who are conscious, you can use your visual analog skill. And if patient's score is greater than 3 for VAS and greater than 3 for CPOT or greater than 5 in DPS, you need to intervene, as that shows that patient is at least having a moderate pain. So in ICU and in COVID care, generally we use fentanyl and morphine. So fentanyl is generally used in patients who are having kidney insult, and as the use of morphine that is that will metabolize to its metabolite and is active will need to be cleared by the kidneys. So the use of morphine in patients who have kidney insult may not be suitable, and fentanyl will become the preferred choice. However, fentanyl is to be noted that it may accumulate in the body, and over time it has this contact-sensitive half-time, which means the clearance becomes a bit more unpredictable with prolonged use. So based on the PADIS guideline and the ICU protocol, generally other adjuncts is very well encouraged, is actually encouraged, although the evidence is not to say very strong, which commonly used would be PCF, tramadol, and in certain patients, you might want to consider gabapentin for neuropathic pain, or patients if patient is conscious and obey command, the use of PCA. However, the use of PCA or remifentanil may not be that feasible in our COVID setting. So all in all, it just falls back to generally our morphine and fentanyl, and the use of adjuncts such as PCM and tramadol. So that's like what I mentioned earlier. Morphine, the concern would be patients with hepatic and renal impairment, and for fentanyl, they will accumulate with time. So other things like oxycodone and gabapentin, which is not really commonly used, and the use of tramadol in is helpful as well as part of the adjunct. So I'll move on to nutrition. So generally, nutrition is very important in critical care patients. It's important to start them early on enteral feeding, means feeding through the gastrointestinal tract. It's just, however, patients that are generally intubated, we would insert, we'll be feeding them through a NG tube or a OG tube, oropharyngeal gastric tube or a nasogastric tube. So the importance of early nutrition is to attenuate the metabolic response to stress and prevent oxidative ciliary injury and modulate the immune response. Of course, to feed through the GI tract is preferred over to give it in the intravenous form. However, if patient for any reason is not suitable for feeding through the gastrointestinal tract, intravenous feeding is will be used. So it's what's the principles are? The principles are mainly to assess the patient's nutritional risk, and in our country, is actually generally noted that we tend to have overnutrition than undernutrition generally. So and it is also noted that obese patient tends to have we tend to have more obese patients that goes into stage 5, as we notice. So what is important to actually commence enteral feeding early, within 24 to 48 hours. However, for the first 72 hours, you need not to push all the way to 20 kilocal or 25 kilocal per kg, and all you need to aim is just about 70 to 80% of it. However, it's important to focus on the protein, which should be at least of 1.2 gram per kg per day. If patient for some reason cannot be fed through the gastrointestinal tract, parenteral nutrition should be started after 5 to 7 days. The reason why, and of course, we need to avoid overfeeding, as anything more than 100% of the targeted calorie will be associated with increased mortality. So of course, whoever who is malnourished will be at risk of refeeding syndrome and should be identified. So so who are at risk of malnutrition are generally those who have pre-existing chronic diseases, those who are underfed for more than 5 days, and those who are admitted to ICU for and mechanically ventilated for more than 2 days. So thankfully, like what I mentioned again, thankfully our patients are overnutrition and they tend to have better reserve. So not all patients needs to be can tolerate enteral nutrition, and it should be delayed in such conditions as such as patients who are in shock with high dose inotrope, as generally those are when patient is hemodynamically unstable, the bloods will be shunted away from the gastrointestinal tract, and it will the patient would you might not want to burden the patient further with feeding. Of course, patients who are severely hypoxemic and in severe acidosis, you might want to delay as well. Those who are having active GI bleed, which is actually quite common in our COVID setting, as we are actually giving them anticoagulants as well. Those who have bowel ischemia or perforation, or those who have abdominal compartment syndrome, and those who doesn't tolerate feeding, which is defined as a gastric residual volume of more than 500 ml in 6 hours. So the concept of why do we not achieve more, we just achieve about 70 to 80% for the first 72 hours is basically this is the stress response to a trauma. So you have up phase and flow phase. So for first 24 and 48 hours, there will be a reduce in BMR, there will be catecholamines circulating around, there will be reduced cardiac output, and of course, the patient has their own reserve. So basically, you need not to push the patient calorie that high when patient is admitted early. So as the phase wears off, the patient will go into flow phase into the catabolic phase, and that's when you start to step up your feeding. And of course, towards the anabolic phase, when patient is recovering and building up, that's when you have to increase your calorie further for better tissue repair and energy for recovery. So inserting a route tube is generally through the nasal or oral path, and is generally of 10 to 12 fronts. And it's important to confirm the placement. And the gold standard is generally the use of confirmed with a chest X-ray. Of course, what we commonly do as in non-COVID patients, we tend to auscultate, but that is associated with false negative placement. And in COVID patients, we don't auscultate. I think some places they actually just feel for the gushing of the air at the abdomen. All right, but whatever it is, just confirm the placement with a chest X-ray before you start your feeding. And if you want to feed, you make sure that it's preferred that the head is elevated, so to prevent aspiration of gastric content into your airway. And that, if not, that would lead to aspiration and promote ventilator-associated pneumonia. So how feeding through a tube can be done is it can be continuous or intermittent or bolus depending on your local settings. So the choice of enteral formulation depends on the patient. It should be individualized. Commonly used are the isocaloric formula, such as Nutritional Optimum or which generally give a calorie concentration of 1 to 1.5 kilocal per meal. However, there may be some different special consideration for patients who are diabetic and have very poorly controlled sugar, especially when they are started on steroid therapy. So this group of patients, you might want to consider giving them like diabetic formulas such as Nutrient Diabetic or Glucosinor. So there are also patients who comes in and requires fluid restricted and requires fluid restriction, and especially when patient is already stage 5 intubated ARDS, you might want to fluid restrict, or patient has underlying chronic kidney disease or go into polyuric kidney failure, you might actually want to use caloric dense formulas such as Nifro or Novasource. So generally, those who are underweight, you just give you use a adjusted body weight, which is the ideal body weight, which means the weight is when the patient is at a BMI of 25, and the midway of the patient. So it's the midway between the ideal body weight and the patient's actual weight. So and you give 20 to 25 kilocal. For those with normal body weight, you just use the actual body weight and give 20 to 25 kilocal. That is the targeted calorie. And those who are obese, you might want to be more careful, and as there's tendency to overfeed the patient if the use of actual body weight is used. That is why if you realize when we use actual body weight for those with BMI 30 to 35, it is actually much lower from the normal targeted patients. And of course, if it's more than 50, you might just want to use 20 to 25 of the ideal body weight. So the calorie requirement is the protein requirement is generally still important, basically to reduce the muscle wasting and promote healing and subsequent rehabilitation. So who are those that are at risk of, so of course, feeding is associated with intolerance. There are people who just can't tolerate the feeding. So it's generally defined as those with high gastric residual volume, those with abdominal distension, vomiting, diarrhea, or reduced passage of stool. So when the patient have a gastric residual volume of more than 300, you might want to use a prokinetic agents, which I think many of you are quite familiar with the use of metoclopramide, aka Maxolon. Usually we give at 10 mg TDS, but don't forget, if patient have kidney impairment, you might want to adjust the dose. And if patient and after, if metoclopramide doesn't work, we generally add on erythromycin. The common dosing that we use would be 250 mg BD, so that we reduce the need to go in and for our staff to go in, to dawn in to serve the medication. However, it's to be noted that both agents are associated with prolonged QT, and it should be used with caution. And it's important to stop the prokinetic as soon as patient is tolerating feeding, and so as soon as the patient is starts to tolerate feeding. So those with diarrhea is generally defined as more than 2 to 3 liquid stool or 250 grams of liquid stool per day. Generally, you don't interrupt your feeding when patient have diarrhea, and what you need to do is you review anything that would cause diarrhea, such as your antibiotic itself, your proton pump inhibitors, as that will reduce the gastric acidity and cause interrupt with the digestion of your feeding. The use of prokinetics, if patient is having diarrhea, you want to off that. And if patient is on laxative such as lactulose. So look at your dietary formula as well. So because there are certain formula that may not be suitable for the patient. So of course, if patient is on antibiotic, which is quite common in our COVID patients, you might want to consider if patient have a Clostridium difficile infection and you want to send a CD toxin assay. Patient have diarrhea, they lose water, they lose electrolytes. Make sure your electrolytes are within the normal range. And if, of course, don't forget, if the lactate is going up, patient having distended abdomen and everything, you might want to rule out any gastric abdomen pathology such as bowel perforation. So if the feeding is not really still not tolerating, there are certain formulas that can improve in the tolerance, such as adding soluble fibers or use of semi-peptides element formulas, such as your Peptamen. So other things is, make sure you keep your sugar between 6 to 10 millimole per liter. Not to try to avoid hyperglycemia, and there's no need to have too strict sugar control of less than 6, as that is associated with greater mortality. Anything more than 10, it is also similarly associated with greater mortality. So if patient has a sugar more than 10, start your insulin therapy. So that generally you don't stop feeding the patient, you don't withhold the patient for procedures, transport, or extubation. What you need to do is just to aspirate. Unless the patient is not tolerating, you might want to withhold the feeding for a while if patient is not tolerating the feeding. Otherwise, generally we don't withhold any feeding. So what's important is after the feeding, this is more for the nurses, you just flush the tube with water, and the water that is given should be calculated as part of the daily water intake. Generally, you don't want the rough tube to be blocked by your milk curds. So who are the patients that might need parenteral nutrition? Generally those who can't tolerate enteral feeding. So if patient can't tolerate enteral feeding and is severely malnourished, you start as fast as possible. If they are of normal build, then you can just wait up to 5 to 7 days. So of course, if after 7 to 10 days and our targeted energy and protein requirement is not met, 60%, then you might need to use supplemental parental nutrition. So what if patient is on parental nutrition? What is important is you make sure you monitor the sugar. You do a daily electrolytes by bi-weekly liver function test, and of course to check the triglyceride level as well. So of course, if patients are malnourished, please make sure that to bear in mind that patients are at risk of refeeding syndrome, which is generally a biochemical changes, clinical manifestation and complication that happens when you feed the patient who are malnourished, and that is basically due to the shift in fluid and electrolytes. As you start feeding, sugar goes into the cell, bringing in your electrolytes such as phosphate to form ATP or potassium into the cell, and that will cause generally the common one will be hypophosphatemia, hypomagnesemia, and hypokalemia. So who are at risk are generally those who are underweight, those who have unintentional weight loss for more than 10% in the past 3 to 6 months, those who have not been feeding well for the past 5 days, and of course those who are alcoholic, or those who have cancer, those who are on insulin or diuretics. Of course, how do you prevent it and manage it is generally to identify who are at risk, and what you need to do is generally give them a lot of vitamins, vitamin Bs, mainly thiamine. So for those who couldn't tolerate orally, you might want to use IV form, IV thiamine, 200 to 300 OD for past 3 days. And once they tolerate orally, you change to oral. Start the feeding slowly at 10 kcal per kg per day, and just step up slowly. And what's important is to hydrate them carefully and just frequent check and correct the potassium, magnesium, phosphate accordingly. So I've basically covered this topic. Make sure the patient is adequately fed, and make sure you give adequate analgesia and sedation. And that is the end of my slide. I'll pass back to our moderator.
Thank you, Dr. Vincent, for the excellent presentation. So stay on. We have quite a few questions for you. So Dr. Vincent, so there's this question on YouTube. There are no questions. Wait, let me see Zoom. Never mind, we'll proceed with the YouTube question first. My patient's on propofol and then his urine turned green. Why?
All right, propofol is actually a phenol. All right, it falls under the classification of phenol group, and that part of the chemical structure actually contributes to phenol. So so basically it's a metabolite of propofol, and that not only would you notice the urine would turn green, sometimes you can see the hair turn green as well. But it is just the metabolite, and it's generally harmless. It doesn't hinder it doesn't mean one really have to stop the propofol, but it's important to check back on the dosing of your propofol and make sure that patient is not at risk of propofol infusion syndrome. And yeah.
Since you mentioned propofol infusion syndrome, just briefly tell us what are the signs we should look out for to suspect this propofol infusion syndrome in our patients?
All right, propofol infusion syndrome is generally like catabolic. The main thing that you might want to be worried of would be rhabdomyolysis and biochemical changes. So you check for when you give a high dose of more than 3 to 4 mg per kg for prolonged time. You just what's important is you look at the biochem, you look at the heart rate, you look for cell muscle breakdown which is raised CK, and you look for signs of rhabdomyolysis, hyperthermia, tachycardia, and of course, brown color urine. So at that point, treatment is supportive, but it's associated with high mortality. So be wary with that as well.
Okay, excellent point. There's one question on our Zoom platform. What is the next step of management if your patient is still asynchronized to the ventilator despite on maximum sedation? So, Vincent, how?
All right. Of course, make sure the drug that you are giving is going into the patient. That's most important. Of course, you assess the patients on the level of the sedation. Of course, if patient is you did achieve your regular -2 or -3, and patient is still in dysynchrony, generally what we do is you add on muscle relaxant. So that will actually help to overcome the dysynchrony. Of course, just make sure you check back on your ventilator, make sure your setting is appropriate as well.
Yeah, excellent point. Yeah, we have a lot of young patients coming in nowadays, right? And they tend to be really resistant to a lot of sedations that we use, and they still quite asynchronous, So, good point. So let's move on to the next question. It's about feeding. When do we decide to withhold the feeding in case of feeding intolerance?
All right. Generally, you withhold feeding when when patient have high gastric residual volume, which is generally defined as more than 300. So, of course, anything less than that, by right, the thing is the proposed when you have a high gastric volume of like 100, 200, people start to withhold feeding, and it's actually recommended to just refeed the thing that you aspirated. But I guess many of our nurses are not very comfortable to just feed back what is aspirated out. So that is something to what. So anything more than 300, you stop and you restart the feeding when the patient is better. But if it's 300, you start erythromycin, your prokinetics, and of course when patient have vomiting, when patient's iron throat starts to go up, when patient have GI bleed, when patient's lactate is going up, and you start to suspect some bowel ischemia, then you might want to withhold all the feedings.
Okay. And I think there are a few more questions on feeding. One of it is regarding calorie calculation in specific population. Quite detailed. Can you just briefly guide us?
So basically, all right, I'll just focus a bit on patients who are in our COVID setting. So generally, very seldom we see underweight patients. But basically, you just take what is ideal and what is the current patient's weight and go in between and give 20 to 25 kilocal. Of course, like what my earlier slides mentioned, you just aim about 70 to 80% of your targeted calorie for the first 2 days and step up accordingly. Which means for 20 kilocal, 70 to 80% would be 14 to 16 kilocal per kg. And those who are of normal weight, you just similarly as you just give 20 kilocal also. The greater concern is generally those who are obese in our setting. So this group of patients, again, my emphasis is on not to overfeed the patient. So it's very important to calculate the right weight for them, depending on which BMI they fall into. This is by ICU protocol. So of course, if they are more than 50, which is a bit less common in our setting, of course, occasionally you do see a couple of that. That's when you use ideal body weight and give 20 to 25 kilocal per kg. And if you happen to be dealing with those 30 to 50, which is more common, you might actually just need to aim 11 to 14 kilocal per kg, which is sufficient.
Okay. So as you mentioned, most of the protocol that you showed here is from our ICU protocol. So
Yes.
in case anybody wants to have a reference, you can actually look it up in our ICU protocol book. Okay. But of course, every center differs, in terms of their practice and what is the local protocol. So there are not always rights and wrongs, but what is familiar in your local setting lah. Okay. So you just go according to that. Thank you, Vincent.